So welcome everybody. Thank you for joining us today and taking time out of your busy schedule to discuss the updated consensus guidelines. In some ways, we can shift some of our practices from trough only monitoring to AUC guided dosing. So a few things. I mean, we only have a limited time here, and I've done a few of these types of webinars, and what I have found is the best part is by far the audience participation. So, rather than having a little bit of build up, I thought probably the best way to begin this presentation is just to jump right into the major changes. So these are some of the simplified recommendations. So first and foremost, in patients with suspected or definitive serious MRSA infections, so again, the emphasis on serious MRSA infections, individualized AUC to MIC target ratio of 4 to 600, assuming a vancomycin MIC of 1, should be advocated to achieve clinical efficacy while improving patient care. With the assumption of a broth MIC of 1 microgram per ml, that equates to a targeted AUC range of 4 to 600 per day. In contrast to the previous guidelines, which recommended, checking level after the 4th dose, given the importance of early appropriate therapy, vancomycin target exposure should be achieved early in the course of therapy, preferably within the first 24 to 48 hours. A few things that come up is, in a situation where you might have an MIC by the gold standard broth microdilution method, when it's greater than 1, it's important to recognize that achieving an AUC to MIC target of greater than 400 is low with conventional dosing. Higher doses may be needed, but there's likely some toxicity risk associated with that, and it's a risk versus benefit situation, and I encourage you to rely on your clinical judgment. Also, the thing that came through, as part of developing the guidelines is, well, what happens if you have a broth microdilution MIC of 0.5 or 0.25? And our current recommendation right now is not to decrease the vancomycin target AUC range, and the reason part is we just don't have data to show that AUC de-escalation is still results in efficacious outcomes. Two other things, as part of the recommendation, trough only monitoring with a target of 15 to 20 is no longer recommended based on efficacy and nephrotoxicity data in patients with serious infections due to MRSA. And again, a question that always comes is, well, who do I apply these results to? And the emphasis is really on patients with serious MRSA infections. And then currently there's insufficient evidence to provide recommendations on whether trough only or AUC guided vancomycin monitoring should be used among patients with non-invasive MRSA infections or other types of infections due to other pathogens. So, those are really, the major changes within the guidelines. That we have some recommendations for loading doses and maintenance doses in specialized populations, including those with obesity requiring renal replacement therapy, as well as pediatrics. So, but the biggest thing is, this kind of move away from trough only monitoring. And again, the whole reason why the 2009 consensus guidelines recommend the troughs of 15 to 20 is really a surrogate of achieving an AUC to MIC ratio of 400. So when we moved to this practice, what we had was an opportunity to really evaluate the outcomes associated with both efficacy and as well as toxicity. And despite this, move across, all institutions, throughout the world, the clinical benefits of maintaining a trough of 15 to 20 have not been well described. There's one study that's notable coming out of Detroit that did identify a link between clinical success and vancomycin trough values among patients with MRSA bacteremic infections. And what they kind of saw was this inverted U curve where failure was high, less than 15, dropped to 40%, and increased again above 20. And looking at this, I think this is somewhat along the lines of an unstable exposure response relationship. But I would argue, a failure rate of 40% is really doesn't get us to the top of the dose response curve. So again, we all say we do this 15 to 20. We did it at our institution, and the important thing to recognize is why we felt good about getting people within that range. There's really not a lot of data to support that maximized clinical outcomes. The other thing when you consider with dosing, not only does it the drug need to be effective, but it also has to be safe. And what we did find is getting people into that 15 to 20 range resulted in an increased rate of acute kidney injury relative to maintaining troughs less than 15. This is a meta-analysis that I was involved in 7 years ago, looking across the literature at the time and saw a very strong relationship between troughs greater than 15 and AKI relative maintaining troughs less than 15. And there was an exposure response relationship noted. In JAC, Journal of Antimicrobial Chemotherapy, there's a subsequent meta-analysis published in this month's edition, which really found a similar relationship. So a few things about the relationship between vancomycin exposure and acute kidney injury. One thing that always comes up is what came first, the chicken or the egg? And so what we did is, this is a study we did many years ago looking at initial vancomycin dosing. Again, this was at a time when the new recommendations for maintaining troughs in the 15 to 20 were released. And what we saw was some heterogeneity in dosing practices at our institution. As a positive control, we included linazol, and it just looked at empiric dosing of those 4 or more grams a day. And really what you found is, first and foremost, over the first few days of therapy, there's no difference in the toxicity curves. And that's the one thing we need to realize with vancomycin acute kidney injury. Like most non-immunologic reactions, occurs after 4 or 5 days. And I would argue that during the first few days of therapy, any bumps in serum creatinine, and this applies to the aminoglycosides as well, is really due to hyperperfusion of kidneys in patients with sepsis. And what you do see over time is the separation of the curves. Okay, the other thing I want you to make note here is, again, when we think about vancomycin acute kidney injury, there's a background rate among patients who we use it in. So again, you go into an ICU, many patients are going to develop acute kidney injuries for reasons other than vancomycin. However, what the literature does tell us is when you do use vancomycin, at more intensive exposures, you have more AKI relative to maintaining vancomycin and less intensive exposure, depending on the patient population you're interested. The more vulnerable, the more AKI you'll see. The less vulnerable, the less AKI you'll see. That's why you see a difference in vancomycin AKI rates in skin patients versus those within the ICU. So the other thing always comes up is, well, we do this whole thing with vancomycin, and it was always thought to be a surrogate of achieving an AUC to MIC ratio of 400. And what we're finding is, it's probably not a good clinical surrogate. So a trough is just an exposure at the end of a dosing interval, and it really varies at a function of, how often the dose is given, is it 2 or 3 times a day, as well as the patient clearance. So probably a more informative exposure variable is the AUC, which is integrated exposure over time. So what a trough does, it does ensure a lower bound of the AUC value, but what you see is up to a 3-fold to 4-fold variation at the top end. So a trough of 15 to 20 is always going to get you at a 400. It could result in a subsequent AUC value, upwards of 1,000, 1,200, even up to 1,600. So, the reason why I make note of this is, as we kind of dig a little deeper into the data, and, what we find is clinically, as you get AUCs above 600, 700, 800, that's where you really begin to see an increased risk of acute kidney injury with vancomycin relative to lower AUC values. Furthermore, there's been a lot of nice work done in animal systems by Dr. Mark Sheets, and really what he has found is, AUC is the driver of acute kidney injury and vancomycin in his infection in his animal system. So he has some biologic plausibility. We know vancomycin is an oxidative stressor in the proximal renal tubule cells. That speaks to the intensity of exposure. Intensity of exposure is best captured by looking at the AUC versus the trough. While the trough ensures a minimal AUC, there's considerable variance between the lower and the upper bound. And the last thing I want to say is, what we have found in practice is, this whole idea of moving the AUC from a toxicity standpoint makes a difference. So there was a nice study published by Mike Neely et al. This was an NIH-sponsored study, Prospective multi-center. And really what he's shown is, over a 3-year period of time, shifting the AUC-guided dosing really reduced AKI rates by 50%. And this is a study, again, coming out of Detroit by Finch et al. And this is kind of a pre and post analysis. And I really like this. And really what they did at their institution, moving to AUC monitoring, they were able to reduce acute kidney injury relying on the vancomycin consensus guideline definition of a 0.5 or 50% increase in serum creatinine from baseline from about 10% to 5%. And really what you see in the AUC guided group versus the trough only monitoring group, you saw a separation of the curves over time, largely occurring 4 or 5 days out, consistent with most non-immunologic drug reactions. And if you kind of look up the hood in this study and look at the AUC guided group and the trough guided group, what you see is just less intensive exposures in the AUC guided group. Troughs, the median trough was 12, the median AUC was 474, and the interquartile range was 360 to 611. In contrast, you look at that trough guided group, again, they didn't even get troughs. The median trough wasn't even 15, it was 14.2. But what they did is they put most patients in that AKI AUC sweet spot, above 700, with about 25% of people having an AUC above 880. So again, the whole reason, that always comes up is, we do see that, from a biologic standpoint, AUC appears to be the driver. It appears to be when you get above, 6, 7, 800, you do see increased events. And furthermore, we have some prospective validation that shows if you shift to AUC guided dosing, you result in lower AKI. And the thing that always comes up is, well, in a lot of my patients, Vancomycin-Associated AKI is mild and usually resolved within 1 to 2 weeks of discontinuation. So we had this idea that, well, even if it does occur, these patients are going to resolve. The one thing you need to realize, when your serum creatinine increases by 0.5, there's already considerable reductions in the GFR. And in the case of vancomycin, there's already considerable damage to the to nephrons. And what you find is when you have a 0.5 increase, you have a 50% reduction of GFR needs to occur before you see that subsequent bump. So even though it does respond, there's a lot of acute kidney injury there. What we find is even patients who have mild cases of vancomycin-associated acute kidney injury have increased mortality, increased attributable hospital stay, and increased healthcare resource utilization. We recently did a study, and what we found is even among patients with skin infections, what we found is a 5-day increased length of stay among individuals who are largely similar at baseline, with the exception of some having AKI and those who have not. If you take a step back and looking at the larger literature, the deleterious outcomes associated with acute kidney injury are well described within the kidney literature. And the other thing we're beginning to say is it's just not a short-term negative outcomes we worry about, but there's long-term consequences. And data suggests that patients with acute kidney injury, regardless of the cause, is often accompanied by remote organ dysfunction or organ crosstalk, which increases a patient's susceptibility to a number of conditions over time, whether it be cardiovascular events, infections due to immunosuppressions, and changing in their metabolic system. So again, it's not just, we have this mild event, serum creatinine goes up, it goes down, and the patient has normalization. Rather, there's this whole sequelae events that occur that affect other organ systems and really sets the patients up for bad outcomes over time. So again, when I think about, the reasons for shifting to AUC, a lot of it's driven by, minimizing acute kidney injury. Okay, and we begin to see that acute kidney injury really increase above an AUC of 600. So that really defines the upper bound of the therapeutic range that we came forward with in the guidelines. The next question is, well, what's the lower range? If you tell me to go, I can't go above 600, how low can I go? So, historically, we always relied on this thought that the pharmacodynamic target for vancomycin is an AUC to MIC ratio in excess of 400 for patients with serious MRSA infections. This is largely derived in animal studies, done in 1987 by Steve Ebert. And we have some clinical validation as well. There's some nice work looking at patients with, Staph aureus pneumonia that really supported this target. The one thing you need to recognize in a lot of these clinical evaluations is they basically used a simple formula based on total daily dose and the estimated renal function. And this is the way they derived the vancomycin clearance to estimate the AUC. Now, we're all clinicians on the phone, and we all recognize that there's considerable interpatient variability. And it's nearly impossible to generate a valid estimate of vancomycin exposure variables in a given individual based on GFR filtration formulas alone, and due to the wide interpatient exposure variability. And the one thing I always say is, ICU, the more different physiologic states in a given population, you can have interpatient variability in exposure profiles of upwards to 50, 60, 70%. This is the whole reason why we do TDM among these patient populations. So the question is, well, what's the lower bound? So this was a study I was involved in. It was a prospective observational evaluation of the association between day 2 vancomycin exposure profiles and failure among adult hospitalized patients with MRSA bloodstream infections, or simply PROVIDE for short. So this was a prospective study, multi-center, across the United States among individuals with confirmed bloodstream infections. Relying on some previous identified AUC and MIC targets using a Bayesian method to estimate the vancomycin exposure profile with limited blood concentration data. And again, this was a method that nearly and all validated as an acceptable way to estimate the AUC, rather than collecting, 5 or 6 samples. We looked at the relationship between day 2 exposures and failure, and we powered the study. We included 250 evaluable patients that have sufficient power to detect a 15 to 20% difference in failure rates between the dichotomous day 2 AUC and MIC exposure variables. So just to jump to the chase, given that we're a little bit short of time, we had AUC, the MIC index to the broth molecular dilution, as well as the E-test. And again, these targets of 650 and greater than 320 were identified in the previous publication. And kind of interesting, what we found is, looking at the failure rates, they're actually more pronounced in those who exceed these critical day 2 AUC to the MIC thresholds. Now, in the multivariate analysis, even though the point estimate suggested that higher AUC and MIC ratios were deleterious and result in higher failure rates, that was not the case, as the 95% confidence bound span 0 in both risk difference analyses. What we did find is acute kidney injury was more pronounced among individuals above these day 2 AUC to MIC thresholds. Now, as we know, when we think about acute kidney injury, MIC is non-informative. Rather, it's the drug exposure that's the biologic driver of acute kidney injury when thinking about vancomycin. So what we did is we did a desirability of outcome ranking analysis. And really what a DOR analysis does is it kind of considers all the potential outcomes possible in a given individual that's of interest to the clinician. And what we did for our analysis here, we had on the one extreme death, on the other extreme, we had treatment success with no AKI, and then you have the intermingling of the two in between. So really what you want to do in these, what you want to see in these DOR analysis, you want to see a lot of purple. And what a lot of purple means, survival with treatment success and no AKI. And really what we found is looking at, quintiles of exposure. And the reason why we looked at quintiles is, again, we had, a little over 250 patients. We wanted to kind of break it into different buckets of patients where we had a meaningful sample within each bucket to make some inferences. We saw no real differences in success when you factored in clinical success with acute kidney injury. But what you found in the lower two quintiles, we saw maximal rates of treatment success, no death without acute kidney injury. So the question is, well, what is those quintiles? The lower one was 94 to 387, and the second one was 392 to 515. I will tell you in that lower quintile, even though the lower bound was 94, most individuals were 350 or higher. So, the people always say is, how low can we go? We may be able to go below 400, but I cannot confidently say that because of all our current dosing, contemporary dosing, most patients are going to be above 400. That was the whole essence of doing troughs of 15 to 20. These data suggest we might want to go lower, but there's inconclusive evidence to suggest that. So for now, based on this analysis, some other, that's how we came up with that lower bound to 400. So again, the other thing I always ask is, well, why do we drop the MIC? And the MIC is less important for several reasons. If you look at large scale surveillance studies, most vancomycin MICs by broth molecular dilution is 0.5 or 1. And in the PROVIDE study, over 95% of the isolates, were 1 or less. There's inherent imprecision MIC measurement with a range of accuracy of plus or minus 1-2 log dilutions. So again, a 0.5 is acceptable to call to 1. It's acceptable to call 0.25. MICs are not, typically valuable within the first 24 hours, first 72 hours of the index culture. So we do have to do empiric dosing, even if we know it's MRSA. And there's a high degree of variability between MIC testing methods, used in institutions relative to the broth molecular dilution MIC method. So the question becomes is, well, if we do want to shift to AUC guided dosing, well, how do we get there? And Ethan will talk a little bit more about the Bayesian method, but we really have one or two ways. We can do a Bayesian approach, or we can reconfigure our first order equations that we're accustomed to using with vancomycin to determine what the AUC is, and then to do dose optimized dosing. So a few things with a Bayesian. I mean, this is a software program, and why it seems somewhat complex, it's rather consistent what we're typically done with vancomycin or aminoglycosides in the past. So you have your structural model. For vancomycin, in most cases, it's a two-compartment model. For your two-compartment model, depending how it's parameterized, you have your parameter estimates for volumes and clearance and their associated exposure. And based on your prior, you're going to get some empiric dosing. Over time, what you're going to enter in is their dosing and collected PK data. And then as part of this, you have your targeted PK exposures. So kind of starting out, what you're going to do is it's going to say, based on your height, age, weight, depending on what your PK model is, it's going to give out some empiric dosing. And as you gain knowledge from that patient through dosing and subsequent levels around that dosing, you're going to get individualized PK estimates, which is going to revise the PK estimates. And depending on what your target exposure is, in the case of vancomycin, it's an AUC to 400 to 600, it will give you a revised dosing scheme to get within that range. So again, the process is very familiar to what we're used to doing. So a few things about this. Again, we'll provide innovative treatment schemes as this front-loading dosing regimen. This is something we always struggle with in practice, particularly with the trough-only monitoring approach. We'll say, give a loading dose, give another dose here, then after a certain period of time, it will give you a maintenance regimen. Concentrations do not need to be collected at steady state, which is a real advantage when we think about vancomycin. As we all know, the importance of early appropriate therapy. The battle is really won or lost from an efficacy standpoint within the first 24 to 48 hours. You can include in covariates as part of your Bayesian prior population PK model. And again, you have the ability to individualize which prior to pick depending on what patient population you plan to dose vancomycin in. In terms of sample collecting, 2 is better than 1. There is some data suggests 1 is okay, but that is typically in your more stable patient populations. The other way, which I know a lot of institutions, is just doing an equation-based approach. What you do is you get a post-distributional peak and a trough. And what you do is you calculate the KE, you back extrapolate the peak, peak minus trough divided by the KE will give you an AUC for that given dosing interval. So a very nice thing about this can be programmed into the electronic medical record system. But please be aware, it's preferred to have PK data on the same dosing interval. It only provides a snapshot of that AUC for a sampling interval. So if it's dosed every Q8, you have to times it by 3 times, and it's not, you get unreliable estimates and not steady state conditions. You can use it there, but it's not preferred. But in someone who's on a fluctuating regimen, it's really hard to use this because there's really no easy way to say someone's going from Q8 to Q12 in the past day or two to figure out what's that AUC for a given 24 hours. Here's just an example. I know I'm kind of getting a little bit short on time here, but this is an example of your peak. You have your AUC, you calculate your KE, you back extrapolate to the theoretical peak concentration at the start of infusion. Peak minus trough divided by AUC, divided by the KE gives you the AUC for that dosing interval. So the question becomes up, which one of these methods is preferred? This is a nice study by Neil and all, which I had the opportunity to be involved in. And really what we had is we had a large data set of patients who received vancomycin, and we had intensive PK. And what we did for every patient is calculated their true AUC with all the PK. And what we looked at is data depleted PK data sets. And what you found is using a Bayesian method or an equation-based approach, both provided you, reliable estimates of the kind of gold standard AUC with a full complement of PK samples. The one thing I would say is the reason why 2 is better than 1. This is just our experience and looking at patients with obesity. When you look at just looking at their trough data, which is on the right here, you get a reasonable ratio of the gold standard versus the trough only estimate of the AUC. But look at the variance there. In contrast, when you have two samples, you really tighten it up. And depending on the approach, and here we just use different priors, you might under or overestimate slightly. So that's why we say when you want to target an AUC, shoot for 525, because depending on what program you use and what model, what prior, there's probably a little bit of variance, some overcall, but from a clinical standpoint, they're all acceptable. So just in conclusion, despite widespread integration into clinical practice, really the clinical benefits of maintaining higher trough values have not been described. No improvements in efficacy. We see increases in AKI. Based on what we know, again, this is our current recommendations. Research is an end of process. Best evidence tell us we should move to AUC guided dosing, largely to reduce the occurrence of AKI, looking at the consequences of AKI, even if it's mild in nature. We have a few different approaches: Bayesian software, first order PK calculators to calculate the AUC with limited PK sampling. And again, I think stewardship teams really play a critical role in implementation assessment of vancomycin AUC guided dosing. So with that, I'll stop. I'll pass it over to Ethan and hope to give you some practical experience with what he has had with the AUC guided dosing approach.